Okay, folks, we're going to be talking about respiratory disorders. So this is going to be anything related to do with the lungs or delivery of oxygen to the lungs or blood flowing through the lungs, right? Anything to do with the lung system. That's really what we're talking about here today. So the 5 disorders that we're going to cover are going to be these 5 in yellow. Pneumonia is going to be one of these disorders that I'm going to have you guys watch your own video. This is a really well done video by osmosis that you can go ahead and find on your own. The link is going to be in the PowerPoint that when you go and download this to take notes, or if you want to come and get this, or if you just search for osmosis video on pneumonia, this is going to be available. Just as a start us off with to get us going a little bit, this is not a disorder that we're going to be talking about because there's not a whole lot to it really, but a condition called chest flail. If you were to get into a car accident or some kind of trauma to the chest, if I break one rib, well, that's okay. The ribs that are on either side of it are going to be able to provide enough structural rigidity to the chest that there's not going to be any big damage. It's going to hurt when you breathe, but it's not going to be that bad. Chest flail is when we have significant damage to at least 3 or 4 different ribs, and if that's happening, well, now those ribs are able to actually move independently of the other ones around them, and you get a condition that looks an awful lot like this. This is a guy that probably, if I'd have to guess, is also on like methamphetamines, but you can see his lung is actually beating out of his chest because there's been some kind of trauma to his chest, and you can see that's not his heart beating, that's every breath he's taking without that kind of tension that can be pulled on the chest. Well, there's really nothing to stop that lung kind of pushing out and ballooning as it fills up with air. Just a quick little review. We've already obviously talked about alveoli so far in this lecture when we talked about COP or coronavirus. Air moves down these ducts. These ducts are going to terminate in these balloons. These balloons are going to inflate and deflate. The alveoli themselves are made up of 2 major types. Type 1, which are the really thin layers that are actually lining the alveoli itself. And then they're not in this picture, but type 2 alveolar cells are going to also be present that help make surfactant. And surfactant is going to keep that alveoli from collapsing. Alveolar macrophages are also not in this picture, and they're really important. Alveolar macrophages are kind of a subtype of macrophages, and they tend to be a really aggressive form of macrophage because they're going to be constantly sucking up dust and junk and stuff that we've inhaled. So because the lungs are a really common interface for our body with the outside world, we want the macrophages there to be really, really on their toes about things. When we're talking about the lungs, so this is a chart that covers a whole bunch of stuff, but really what this is trying to get across is that we could be talking about something that has to do with the circulatory system, right? The heart or the blood vessels that are leading to it. We could be talking about something that is in the muscles or muscle control mechanism. So we could be talking about a brain problem that causes a muscle problem that causes a lung problem, right? So, or we could be talking about something that's actually affecting the lungs themselves, stuff like COPD or cystic fibrosis, right? So these are, because the lungs are so intricately tied with a lot of other systems, it's very easy for something to affect the lungs, just in the same way that it's very easy for something to affect like the heart or cardiovascular system. We've already talked about ARDS, so I don't have to go too in-depth on ARDS. Remember, Ards is going to be kind of an end point. It's not one disease. There's lots of different things that cause ARDS, but what you're seeing with ARDS is you're seeing a rapid onset because it's an acute syndrome, and you're going to see pulmonary edema, right? So the edema that we see with where left-sided heart failure is going to be causing a backup into the pulmonary system, that's not going to be something that's going to happen very rapidly. That left-sided heart failure is going to get worse and worse and worse over time, but that's more of a chronic condition. When we're talking about ARDS, that's something that's happening really fast, right? So we could be talking about trauma to the chest. We could be talking about some sort of infection, some hypersensitivity and inflammation, right? What we talked about previously, disseminated intravascular coagulation that's coming from something like rhabdo or similar effects like coming from coronavirus, right? Everything that we're talking about causes a big, giant, outsized inflammatory response. It is the inflammation that ends up causing a lot of the problems associated with ADRS. Because as that alveoli becomes more permeable, more stuff is able to move through, including a lot of water. Right? I've already drawn ADRS. You can go back and look at the coronavirus lecture that we did to talk about what ARDS is. Broad strokes, though, remember that this is water entering into the cell, right, entering into that alveolar chamber because we have inflammation causing increased vascular permeability, more fluid jumping out. We cause inflammation, and that inflammation causes fibrosis. That fibrosis causes the cells in the area to become more fibrotic. As that area is fibrotic, it's not going to be as pliable, and you can't stretch it as well. And additionally, you also have a lot of pus forming if we have some sort of infection that's causing this problem. Right? So all of these are going to lead to the major class symptoms of ARDS. They end up with damage to the alveoli because not only is it going to be filled with fluid, but it's also going to be heavily inflamed. And those type 2 alveolar cells, those type 2 pneumocytes, the lung cells that are supposed to be dumping surfactant into that alveoli, well, if they get inflamed, you damage those type 2 cells. No surfactant means as those alveoli collapse, as I breathe out, my alveoli are being shrunk, and some of them are actually sticking to each other's walls. As they stick to the wall, well, now there's no surfactant, they won't open back up. So not only do I have all of these other problems, right? It's filled with fluid, filled with fibrotic material that blocks the diffusion of gases, but additionally, if I don't even have these alveoli open, well, they're not going to work. I'm not going to be able to have air enter into them at all. And when we're talking about fibrosis, remember compliance of the lungs are stretchy, right? These alveoli are flat, and then as I breathe in, they hyperexpand. As this fibrosis is occurring, now my lungs aren't going to be expanding as much. They're not going to be able to house as much new air every time I take a breath in. And as I breathe this air out, I'm not able to actually express as much of this air, right? It's not, it's kind of a balloon that is kind of been blown up too many times. It's a little bit too inflated. This fibrosis also gets in the way of these respiratory gases, right? A lot of collagen is going to block the ability for oxygen to move through this tissue as they start to kind of separate the blood vessel from the alveoli itself. You can always remember ADS as the big 3 Fs, right? Fibrosis, fluid in the alveoli, and failure of surfactants. We've seen an x-ray of COVID patients where you see a pretty characteristic inflammatory syndrome. This is another view of this, right? You get a kind of broad, diffuse white sign on x-ray. You get a whiteout because there's just inflammation everywhere inside the lungs, right? The more inflammation, the more fibrosis, and the more fluid, and that's blocking these x-rays as they're passing through, making the color appear more light, almost like it's all bone, right? It's thicker material, like fluid and collagen. The big problem when we're talking about ARDS patients is you have hypoxemia, right? So they have low oxygen in the blood because of all the things we've talked about. The air itself can't get into the alveoli. The air that does get into some alveoli is going to run into fluid. The air that does dissolve into that fluid has a hard time jumping into the circulatory system because of all the inflammation. This is sometimes called refractory hypoxemia because refractory is it doesn't get fixed by putting someone on oxygen. If my lungs are operating correctly and you put an oxygen mask on me, hey, it's basically making my lungs, the work that I'm asking my lungs to do is significantly reduced because I'm inhaling a bunch of oxygen. It's not that hard to get oxygen in. If you put a ARDS patient on an oxygen mask, well, they're not actually going to get any better because that oxygen is not getting to the alveoli anyway. Right? This has been a point of contention for a long time, even before coronavirus. We've been actively running, hey, are we supposed to be putting people on positive pressure so that we not only just allow their lungs to suck air in, but do we like actively pump and force air in? Or is that something that actually can cause more damage, right? So it's an active point of discussion, and you're probably not going to get told any one answer when you're actually out in treatment and managing this. This is what this is going to look like, right? Someone with ARDS is going to have their fluids heavily inflamed. Their alveoli are going to be filled with pus and filled with fluid, right, from all of the stuff jumping out of the circulatory system. This is not a particular disease. This is a syndrome. So it is the effects coming from something else. So really, if you're trying to clear up ARDS in a patient, you have to clear up what it actually caused in the ARDS. Right? There's no solution to ARDS. Putting someone on oxygen doesn't make the problem that caused the ARDS go away. The other thing that I'm going to talk about is COPD. COPD is kind of a catch-all term for a lot of different disorders. Emphysema and chronic asthma and chronic bronchitis being the three big ones that we really discuss when we're talking about COPD. These are obstructive disorders in the fact that they prevent oxygen from getting to that alveoli, right? So you're going to have a hard time moving oxygen and moving air around the lungs themselves. I believe it is still the third leading cause of death for this year. We're getting a run for the money currently from coronavirus, but that's something that this is a pretty common thing. A lot of people in the U.S. are going to experience COPD or know somebody that has COPD sometime in their life. Emphysema is the most common of the three. It's a pretty easy thing to understand because, hey, if you are ingesting a environmental irritant intentionally by smoking a cigarette, or generally cigarettes are the main cause of it, that is going to be a pretty obvious sign of irritation. The lungs get irritated, the lungs get repetitively irritated. Well, now we have a chronic condition. If we're talking about other countries, particularly places in South Asia like China and India that have pretty bad pollution problems in some areas, that actually is a more common indicator in addition to smoking. And then one thing that we're going to talk about is something that is a little bit less clearly identified, but something called alpha-1 antitrypsin deficiency. So we're going to talk about that when we get to it. But remember, emphysema is an obstructive disease. So when we're talking about obstructive, it's as in air is not able to move within the lungs. It's not that it's restrictive, but it is obstructive. The air is not able to pass through. So when we actually are able to get air in the lungs, that lung is actually going to start swelling, right? So the lung is trapped, the air is trapped within the lungs and can't get out in these obstructive disorders. So real quick, let's draw a little bit on how emphysema works. So when we're talking about emphysema, we're really talking about a condition that's going to cause in the alveoli themselves and in the alveolar ducts that are leading to those alveoli. Right? Remember, the alveolar ducts are these small little tubes, and then they're going to branch off into these small little they kind of grape balloon sacs that are coming off of them. Right? So these are our alveoli. If we are consistently ingesting something like smoke, right, where we are exposing ourselves to these environmental irritants, right, this smoke is going to be moving down into the lungs, and it's going to be causing inflammation. It's going to be causing irritation. This irritation and this inflammation is going to cause a problem, right, because as the smoke causes the inflammation, well, that inflammation does exactly what it's supposed to do. That inflammation does things like recruiting immune cells, right? So the inflammation recruits immune cells, particularly things like macrophages and neutrophils. As we have these macrophages and neutrophils showing up on site, right? They're ready to fight. They're ready to start attacking whatever's causing damage to our lungs. it's not a cell, it's not a virus, it's not a bacteria that's causing damage to our lungs. So when these immune cells start showing up, things like our macrophages and things like our neutrophils, they're going to start dumping out their products that are built to attack and destroy the things that we would expect to be there and causing us harm, right? Bacteria or something. So these immune cells are going to start generating and dumping out a lot of proteases. Remember what a protease does. Ace on the end of anything tells you that it breaks the thing on the front, right? So proteases destroy these proteins, particularly things like collagenase and elastase. So these proteases are going to be damaging the fibers that are wrapped around these tissues that allow the lungs to have some level of stretch while still maintaining rigidity. So if all of these proteases end up damaging and destroying these, well, we have two big problems that now happens in the lungs. Simultaneously, we have issues because elastin gives that stretchiness. So elastin, you can think about when an alveoli is swelling as you're inhaling air, that alveoli is swelling, the elastin around that provides that ability to stretch, but also that ability to snap back. So breathing in is an active process. We're pulling air in, but as soon as we have a full lung of air, it's a passive process to push that out because our alveoli are already trying to contract because of the actions of elastin. Right? No elastin means you have a reduction in the stretchiness. Right? The plasticity is gone. Elastin, if you lose elastin, the lungs aren't stretchy. It's not elastic. The other thing that matters is collagen. Collagen is not all about having this kind of stretch effect, but what collagen is providing some structural rigidity and actually allowing these structures to stay open. So we're going to see a lot of this collagen in these ducts and in these large air vessels that are allowing air to move through. So the rigidity is also lost when we end up producing a lot of these proteases, because some of these proteases are elastases that blow up elastin, and some of them are collagenases that blow up collagen. Well, the problem comes when we consider something called the Bernoulli Effect. And we're going to get a little bit into the weeds on physics here, and that's okay, because we're going to talk very in-depth discussion about how this actually affects things. When I am breathing in, right, when I have air passing into my lungs, a new breath that's being drawn in, that new breath is going to, unsurprisingly, cause this alveoli to swell, right? And at the same time, it's going to be pushing on the walls, keeping the walls open. So that is why individuals with emphysema are able to generally get air into their lungs, because the air is pushing everything open. If we now think about what's going on in a breath out, right? This alveoli is full of air, and now it's ready to start moving this air out. Well, if you've ever, the Bernoulli effect is all about as air is moving rapidly, it causes a change in pressure. So as this air is moving out of the alveoli, it actually tugs a bit on the walls, right? Why is it not tugging on the way in? Well, on the way in, it's also filling up the alveoli, right? So that the air is also expanding the alveoli and alveolar ducts. But now we're getting rid of all this air, and this air is actually doing a little tug on the walls themselves. So when we're talking about somebody with emphysema, this Bernoulli effect, I don't have a lot of elastin, so I can't expand this alveoli, but additionally, I have a loss of collagen. And now if I have air rushing out of these alveoli, they're actually going to cause a collapse, right? These alveoli are going to not only be unable to inflate, but now the ducts that are leading into the alveoli are going to get smaller. So now I have a big pocket of air inside my lungs that I can't ever actually get out. You've experienced the Bernoulli effect. I'm just going to write down Bernoulli so we know what we're talking about. You've experienced the Bernoulli effect if you've ever been like near a subway line and the subway car goes by, or like near a bus or a big car or something, and the bus goes close by you, and you feel almost kind of sucked in by the air as it's passing. That's the Bernoulli effect, right? That bus is causing a drop in pressure around you, so you're actually getting sucked towards that pressure differential. That's the Bernoulli effect, and that's what's happening in your lungs as well. So when we're talking about how this affects the individuals within COPD, right, these emphysetic lungs are going to start actually combining, and they end up not necessarily having lots of different little tiny grapes, but one big honking cluster, right? One big giant single cluster with shrunken vessels that are actually passing to it, shrunken air vessels. So this emphysetic alveoli is going to have a problem because you're not going to be able to actually have as much diffusion across these tissues. Whereas if you have a bunch of little ones, right, they're all wrapped in a lot of blood vessels. All of those blood vessels have a lot of access to the air within it. If I have one big giant vessel, well, the only place that my blood vessels are here on the outside. They're not going to be able to have much surface area with that air. So not only is this going to cause a problem with the movement of oxygen, but I also reduced my blood's access to the air that's being brought in. Again, most of the time when we're talking about individuals that have emphysema, this is caused by smoking. Smoking is the number one thing. In individuals that also are smokers, you can have something called alpha-1 antitrypsin deficiency. Well, remember, elastases are the enemy here, right? These are the bad guys. We don't want too much elastase. If you're a smoker, you're generating too much elastase because you're inflaming the lungs every time you take a puff. We need to have elastin. Alpha-1 antitrypsin is a normal enzyme that is produced by our immune system that actually inhibits the actions of elastase. It kind of says, hey, we don't want too much destruction. It's kind of a checks and balances system on this elastase molecule. Well, if you have alpha-1 antitrypsin deficiency, well, that means you don't make enough alpha-1 antitrypsin, right? So now you get this outsized effect where a little bit of elastase release ends up doing way more damage than it should under normal circumstances, right? Even if you're not a smoker, my alveolar macrophages, I don't smoke, but my alveolar macrophages are constantly clearing away junk and dust, and I just cleaned out my basement, so tons of, I assume, old skin cells from the people that lived in the house before me, right? That's all now in my lungs. So those lungs, my alveolar macrophages are clearing away all of this debris so that I don't have my lungs collapsing. If I don't have alpha-1 antitrypsin, even normal rates of digestion, right, just from clearing up a little bit of gunk and goo that makes its way down into my lungs, lead to an outsized effect and way more damage than we would expect. So most people with alpha-1 antitrypsin deficiency, most of them are not going to degrade into COPD, but if you're somebody that has this deficiency and you're a smoker, it's pretty much a guarantee that this is going to occur, right? This is a little Socratic question. Everybody obviously gets credit on all these as I go through. Why does this reduce oxygen diffusion? Well, the two options are more air enters the alveoli and less air enters the alveoli. Well, pretty much the same amount of air enters the alveoli because it's the same rough size of the chamber, but we end up having lower surface area. You can think about the fact that now in this drawing, the blood vessels are going to have this much access, and all of these little tiny nodules are all going to have blood vessels lining them. But if I have a emphysetic lung that has kind of coalesced into these big giant spaces because of a degradation of the collagen and elastase, well, now all of a sudden I don't have that much interaction point between my circulatory system and the oxygenated air that I'm trying to pull that oxygen out of. Asthma is also an example of something that leads to chronic obstructive pulmonary disorder, right? It is a pretty wide range of severity, so there can be very severe asthma and very mild asthma. All of this is going to be caused by an outsized response to some external stimuli. Either the eosinophils or neutrophils show up and overreact to something that isn't that big of a deal, right? A little bit of pollen, right, can lead to an asthma attack. As this chronic asthma becomes more of a problem, we end up secreting a little bit more mucus to help deal with the fact that, hey, we think that something's causing a lot of harm to us. So we're going to start pumping out mucus to try and capture these harmful effects, right? Whatever we're inhaling that's causing the asthma effect. Then when we have eosinophils show up, these eosinophils trigger the kind of muscular spasms that are good when we're dealing with a particular threat, but when this is happening throughout the lungs, all of this constriction leads to my bronchioles, the vessels that are carrying the air from my trachea down into the alveoli, they start to shrink, right? This becomes a big problem in COPD patients, right? This is what we're talking about with chronic, in the fact that over years and years and years of this inflammation, we're going to start having scarring occurring. And as we have a more scarred alveoli, right, this scarring is going to prevent the plasticity, and it's going to prevent these vessels from being able to contain as much air, right? The lumen is the space within the vessel that is carrying the fluid or the air or whatever that's traveling through it, in this case the air, and the lumen is now a lot smaller because of the thickening of both the scar tissue itself and because of the basement membrane. So this is another example of chronic obstructive. There's going to be something called chronic bronchitis, right? Chronic bronchitis is sometimes not considered part of COPD. Sometimes it is. It's kind of a who you talk to about it. There's the big difference between the chronic bronchitis that you see and you see the changes that you see in emphysema is it's not so affecting the alveoli themselves, but it's affecting the bronchioles themselves. And chronic bronchitis is generally going to produce something called a productive cough. It is productive because when you cough, phlegm comes out, right? Schmutz comes out of schmutz is not a technical term. When phlegm is coming out of the throat, right, it's a productive cough because of all of this mucus that's being generated, right? In bronchitis, it's also caused by, surprise, surprise, smoking. As you smoke, you end up damaging those cilia that are normally there to help push this mucus up and out of the mouth, right? We catch a lot of the gunk and stuff that would potentially cause us damage in our alveoli. We end up catching that in the vessels that are bringing that air down to the alveoli. Well, this irritation kind of stimulates these goblet cells that are producing the mucus to start producing more of this, right? So this ends up producing so much mucus that you can actually entirely occlude some bronchiole, right? Some of these small air vessels are able to be completely blocked by the mucus that's being generated to deal with whatever the irritation was, generally smoking. This is why individuals with bronchitis, you could hear them trying to cough up a lung, right? When you're coughing, what you're trying to do is you're trying to break this mucus apart. You're trying to push the air and bring up all of this excess mucus, right? So this is just a little chart I made to try and help us differentiate, right? All of this is going to lead to problems with breathing, and the problem with breathing is going to lead to low oxygen, right? So all of this is going to happen. The differences between emphysema and bronchitis is this a productive cough, right? Is this mucus, or is this just a cough that is being not generating any kind of, nothing's coming up out of that cough? The difference between a bronchitis effect and a chronic asthma effect is this something that's happening all the time, or in examples with like chronic asthma, is it some irritant that is there causing temporary bursts of breathing problems. No matter what we're talking about, the endpoint of COPD means that we have low oxygen because of the inflammation within the lungs. And this leads to hypoxia because this part of the reason why it leads to hypoxia is it actually affects the way that blood vessels move throughout the lungs themselves. As the blood vessels are moving through these alveoli, the blood vessels are actually constricting and changing in response to local conditions within the lungs. This is a normal thing that is supposed to go on, because if I get a little bit of phlegm inside of an alveoli, right, it becomes blocked and filled with junk, right, just from regular life, I don't want to send blood to that alveoli. I want to actually restrict that alveoli. So by restricting the amount of blood that's flowing to that alveoli, I shunt more of it towards the more effective alveoli that are actually still working, right? This is hypoxic vasoconstriction under normal circumstances. This is the way it's supposed to go. It's a way to reroute to the more efficient areas in the lungs. The problem comes if I have hypoxic vasoconstriction happen everywhere, right? I'll just do it in paint. If I have hypoxic vasoconstriction in small portions of my lungs, then that's fine. That's great, right? I'm just going to draw my alveoli. So here's an alveoli. Let it go. So under this condition, if I have a bunch of alveoli and I have blood vessels being lined up that could either shunt towards one or the other, right? The blood vessels are flowing through and passing around these alveoli and draining and picking up oxygen throughout that. This is the way things are supposed to go, is as one of these starts to falter, I'm going to vasoconstrict the vessels that are traveling around those alveoli. If I'm a blood vessel and I'm detecting that the blood that's passing through me is still low oxygen, well, I can tell you that that's a sign that obviously this isn't working. So by vasoconstricting, it's putting that blood in a more effective area. So if I have some kind of diseased alveoli, something's gone wrong with it, well, I'm going to vasoconstrict the blood that is supposed to be going to that alveoli, and so that blood ends up being shunted more towards the areas that are more effective. In COPD, well, whether we're talking about bronchitis or emphysema, whatever we're talking about, well, all of the alveoli aren't working right, or at least a lot of them, right? So as more of these alveoli are ineffective, it's going to continue to vasoconstrict and continue to cause more shunting to the point that almost all of the blood is flowing through a very small number of capillary beds. Well, there's only so much space to go around, right? Remember what happens when you change the volume of blood flowing through the same size of vessel, right? We have an increase in pressure within the system. So COPD is going to lead to this pulmonary hypertension. Right, pulmonary hypertension then leads to, hey, it's really hard to pump into the pulmonary circuit. So which of the heart that's going to start failing? Now we're talking about right-sided heart failure. Right, pulmonary. This is a clear example of cor pulmonale, right? The thing that we talked about in the cardiac system, where problems in the lungs lead to problems in the heart, right? Because these things are so intricately connected. Right. This is just another diagram that shows exactly what we just talked about, right? A lung problem leads to a heart problem, cor pulmonale at its core. How do we deal with COPD? How do we treat it? Well, we get rid of the problem, right? We stop the person smoking, get them out of a polluted area, but here in the US, it's really just preventing smoke. We can give them oxygen, and oxygen works well in patients with COPD because they still have open alveoli. It's not something like ARDS is occurring yet, but it's not going to cause the root cause of the problem. It's not going to deal with the root cause, and the COPD is going to continue to get worse and worse and worse, really no matter how much oxygen you're giving them. I'm going to stop here and do a little break in the clip